Welcome to Crisis in Perception, where we examine the systems shaping our world. Today, we are doing a deep dive into an area that, well, it's something that touches literally every single person at some point.
Right. Every person, every family.
Yeah. We're looking at T.R. Reid's book, The Healing of America, a global quest for better, cheaper, and fairer healthcare. But let's just set the ground rules right up front for you listening. This is not a book review.
No, not at all.
We aren't, going over the pros or doing chapter summaries. Worst books for us are entry points.
Exactly. What we are doing today is a systems-level institutional analysis. We're using Reid's journey, his literal physical journey around the world, to look at something far more profound. Because the core identity of a nation, the actual truth of what a society values, is found in the systems it builds.
Yeah, you can tell what a country cares about by looking at its infrastructure.
100%. Today, we are examining modern national healthcare systems, not just as medical networks made up of doctors and stethoscopes and hospital beds. We're looking at them as massive, intentional, institutional architectures.
Architectures. I like that word for this.
Because they are built. They are structures engineered from the ground up to allocate risk, price care, and ultimately define a society's moral obligation to its own citizens.
And I want to speak directly to you right now, the listener. You have almost certainly felt the friction of these systems in your own life. You felt those gears grinding against you.
Yeah, absolutely.
Maybe you've spent, 3 hours on a Tuesday decoding a completely baffling medical bill. Or you've waited on hold with an insurance company trying to figure out what a prior authorization actually means for a prescription you've taken for years.
Or just having to sit down and run the math on whether you could even afford to have a doctor look at a lingering cough.
Right. You've felt the system working around you or failing you entirely. So today, our mission is to strip away all the exhausting, hyper-partisan political noise. We're going to look at the pure, underlying mechanics of how different nations across the globe solve the exact same human vulnerabilities.
It's an incredibly revealing lens. Because underneath all the cultural variations, the localized politics, the national histories, every healthcare system on Earth is essentially a set of answers to three very specific structural questions.
Three questions that define everything.
Everything. The entire architecture of care, whether you're in Tokyo or Berlin or Chicago, comes down to this. Number one, who pays? Number two, who controls prices? And number three, who carries the risk?
Who pays? Who controls prices? Who carries risk?
Exactly. How a nation chooses to answer those three specific questions dictates exactly what kind of reality its citizens will experience the literal moment their biology fails them.
Okay, let's unpack this. Because Reid lays out that when you look across the industrialized world, nations have basically answered those three structural questions by building one of four foundational models.
Right, the four global models.
And understanding these four models is kind of like getting the Rosetta Stone for the entire global healthcare debate. If you don't know these, you can't really understand what's happening. So let's start with the first one, the Bismarck model.
Ah, yes. Bismarck.
We're talking about countries like Germany, Japan, Switzerland, France. In this model, the doctors are private, the hospitals are private, and the insurance plans are private. Which, on paper, that sounds exactly like the United States.
It does sound like the U.S. at first glance. Private, private, private. But there's a massive fundamental divergence in the incentive design here.
Yeah.
To really understand the Bismarck model, we have to look at where it came from.
Right. The history is wild on this one.
It is. It was named after the Prussian Chancellor Otto von Bismarck, who invented it way back in 1883. And Bismarck was not some bleeding heart liberal or a utopian socialist.
Not even close.
He was a ferocious, iron-fisted, deeply conservative aristocrat. He was trying to unify the German Empire, and he was terrified of the rising Marxist Social Democratic Party.
He wanted to cut them off at the pass.
Exactly. To steal the socialist thunder and secure the loyalty of the working class to the state, he instituted a mandatory system of sickness funds. And that exact DNA survives today in countries using this model.
Right, but how do those sickness funds operate in a modern economy without just turning into Wall Street hedge funds? I mean, like American insurance companies do. If they are private entities, what stops them from prioritizing profits over patients?
That is the genius of this structural design. The sickness funds are private, yes, but they are legally mandated to be nonprofit charities.
Nonprofit charities, that is the key difference.
It changes everything. They are financed jointly by employers and employees through payroll deductions, which is a concept Bismarck himself pioneered. They are legally required to cover everybody, regardless of pre-existing conditions. And they absolutely cannot make a profit on basic health coverage. They exist solely to pool risk and pay medical bills, not to pay dividends to shareholders.
But wait, if the sickness funds in Germany are completely private, but they aren't legally allowed to make a profit on basic coverage, what's their incentive to exist at all? Why would a private entity operate without a profit motive?
It's a great question. They actually do compete for members, but they compete on administrative efficiency and customer service, not on excluding sick people.
So they want to be the easiest fund to work with, not the one that denies the most claims.
Exactly. Executors at these funds are paid well based on how effectively they manage their member pool, but the capital itself doesn't get extracted out of the system to benefit external investors. Furthermore, it's a multi-payer system, but with incredibly tight regulation on medical services and fees.
The government steps in there.
Yes, the government forces all these individual sickness funds and all the medical providers to sit down at one table and negotiate a single national price list. This gives the system massive cost control clout while maintaining private delivery.
Which is a perfect segue to the second approach, which takes a very different path. The Beveridge model.
Named after Lord William Beveridge.
Right, the British social reformer. You find this model in the UK, obviously, but also Spain, Italy, Cuba. And this is what Americans generally think of when they hear the phrase socialized medicine.
This is the purest form of it, yes.
In this system, the government actually owns the physical hospitals. The doctors are often direct government employees, though some are private contractors who collect their fees solely from the government. And the bills are paid completely via general tax revenue.
And the historical context here is just as crucial as Bismarck's. The British National Health Service, or NHS, was born out of the absolute devastation of World War II. The country was bombed out, bankrupt, and deeply traumatized. But they had just survived that horrific period by pulling together as a unified collective. The architect of the NHS, Aneurin Nye Bevan, was a pugnacious, die-hard socialist and a former coal miner.
A totally different ideological background than Bismarck.
Night and day. Bevan believed that the capacity to survive an illness shouldn't depend on your bank account. So he built an architecture where medical treatment is viewed as a public service, exactly like the fire department, the police force, or the public library.
You don't get a bill when the fire department puts out a fire at your house.
Exactly. And the outcome of that specific design is the total elimination of the medical bill. You do not get a bill at the point of service in the UK.
It's hard for an American to even conceptualize that.
If you have a massive heart attack in London, you go to the hospital, you get surgery, you recover, and you walk out. No copay, no deductible, no out-of-network surprise billing. The government is the sole payer, which means it completely controls what doctors can do and exactly what they can charge.
And from a systems engineering perspective, that creates an architecture with remarkably low administrative costs per capita. I mean, you don't need armies of billing clerks if there are literally no bills to send.
Right, you don't need collections agencies. The complexity of the financial transaction is reduced to zero at the patient level.
So we have the heavy privatization of Bismarck and the heavy government ownership of Beveridge. That brings us to the third framework, which is essentially a hybrid of the two, the national health insurance model.
Or what is most commonly called the single-payer model.
Right. This is what you see in Canada, and importantly, in newly industrialized powerhouses like Taiwan. In this model, the providers of healthcare, the doctors, the hospitals, they are firmly in the private sector. But the payer is a single government-run insurance program that every single citizen pays into.
Taiwan is actually the most fascinating case study for this model in the entire book.
Oh, it's incredible what they did.
In the early 1990s, Taiwan was a rapidly growing economic tiger, but less than half their population had health insurance. They realized this was a massive systemic vulnerability for their society. So what do? They essentially went window shopping across the globe.
They just looked at everyone else's homework.
They really did. They formed a national commission, flew experts all over the world, studied the US, studied Germany, studied the UK, and they systematically cherry-picked the best elements while discarding the flaws.
So Taiwan basically built a Franken system from scratch in 1995.
Completely from scratch. They wanted the fast access and private innovation of the American and German delivery systems, but they wanted the ruthless financial efficiency of a single public payer like Canada. Because there is only one payer, the government insurance fund, there is zero need for marketing.
There are no Super Bowl ads for health insurance in Taiwan.
Exactly. There are no expensive underwriting departments designed to screen out sick people and deny claims. And there is no profit extracted from the financing layer at all. This makes the system incredibly simple administratively. It also gives the National Insurance Plan immense market monopoly power to negotiate for lower prices on everything from MRI machines to pharmaceutical drugs.
Which is huge.
Yeah.
Okay, and then there's the fourth model, the out-of-pocket model. And while we spent a lot of time debating the first three in the West, we have to acknowledge that this fourth model is the reality for the vast majority of the human population on this planet.
It is the default state of the world.
Right. It's found largely in developing nations, Cambodia, rural areas of India, parts of sub-Saharan Africa. It is exactly what it sounds like. There is no systemic risk pooling. There is no mass medical insurance framework, private or public.
The rules of this model are as simple as they are brutal. The wealthy get medical care, and the poor stay sick, or they die.
It's just market forces applied to biology.
Pure, unmitigated market forces. If you have money, you pay out of pocket in currency. If you don't have money, you don't get the surgery. Maybe you pay in bartered goods like potatoes or labor, or you rely on a local village healer. But there is no institutional architecture shielding the individual from the financial devastation of illness.
So those are the four foundational models: Bismarck, Beveridge, national health insurance, and out-of-pocket. Now let's look at the United States.
This is where it gets crazy.
This is where the institutional analysis gets completely surreal, because the U.S. doesn't use one of these models. It uses all four of them simultaneously. We have built this astonishing, deeply fragmented, crazy quilt of healthcare, strictly fractured by a citizen's demographic status.
It really is a crazy quilt. The American system isn't a single system at all. It is a series of overlapping, often contradictory demographic silos. Let's break down the architecture. If you are a working person under the age of 65, your reality operates basically on the Bismarck model. You and your employer share the premium for health insurance that pays private doctors.
But there is a massive, fatal caveat there.
A huge caveat.
The American insurers for working people are almost entirely for-profit entities. Unlike the sickness funds in Germany or Japan, American insurers answer to Wall Street. Their primary institutional goal is generating shareholder value, not providing health care.
Correct. But then the system completely shifts if you look at a different demographic. For Native Americans, military personnel, and veterans using the VA system, America is Britain.
It's the Beveridge model.
It is a pure Beveridge model. The doctors are government employees working in government-owned clinics and hospitals, and the patients never see a medical bill. It is one of the purest forms of socialized medicine on Earth, operating right inside the United States.
And then, the very day an American turns 65, they enter an entirely different architecture again. For those over 65 on Medicare, America is suddenly Canada. It becomes a national health insurance, single-payer model where the federal government pays the bills for care delivered by the private sector.
The government also carved out people with end-stage renal disease into this single-payer system, regardless of age, which is its own fascinating historical quirk.
Right. And finally, for the roughly 45 million uninsured Americans, and that number fluctuates, but it remains staggering, America is rural India or Cambodia. They are trapped in the out-of-pocket model.
If they get sick, they pay cash, they go bankrupt, or they rely on emergency room charity care. Which, by the way, is the most expensive and inefficient way to deliver medicine imaginable.
It is a dizzying patchwork. Reid points out that all the other industrialized developed countries settled on one model for everybody, one set of rules treating every patient equally, pooling the risk of the entire nation. But the U.S. system defies every standard classification because it relies on this chaotic overlap of all four.
Which brings us to a crucial concept in systems-level analysis: incentives. Behavior by design. We have to understand that systems produce exactly what they are designed to produce.
They aren't broken if they're doing what they're built to do.
Precisely. A system is not broken if it is doing exactly what its incentives demand. When you look at the U.S. crazy quilt compared to unified foreign systems, you are looking at totally different incentive architectures. How you write the rules of financing dictates the reality of the medical care delivered on the ground.
Let's get out of the abstract here. How does that actually play out on the ground? If I'm a patient or a doctor in one of these systems, how do those rules change my reality?
Let's look at centrally negotiated prices as a prime example. In Japan's Bismarck system, the government's Ministry of Health and Welfare sits down every 2 years with the Japanese Medical Association and the insurance executives. They negotiate a massive, physically thick book called the National Fee Schedule.
Like a menu.
Exactly like a menu. This book dictates the precise, legally binding price of every single medical treatment, pill, bandage, and procedure across the entire country. Under this system, an MRI in Japan is set at roughly $98, period.
Wait, $98? How does a private hospital in Tokyo even keep the lights on if they're only allowed to charge $98 for a multi-million-dollar machine? In the US, an MRI can easily cost $2,000 or $3,000.
They survive through volume and efficiency. When prices are negotiated centrally like this, providers automatically adapt their behavior. If a Tokyo hospital knows they will only get $98 per scan, they don't buy an MRI machine and let it sit idle half the week. They run it non-stop, efficiently scheduling patients back to back.
They have to maximize the use of the asset.
Right. And furthermore, they don't have to hire 20 people to argue with insurance companies to get that $98. The payment is guaranteed and instantaneous. The incentive for the hospital is operational efficiency, not price gouging.
That makes total sense. Contrast that with the fragmented risk and profit system in the US. We rely on hundreds, maybe thousands, of different for-profit insurers, all negotiating their own secret rates with different hospital networks.
In that fragmented system, the incentives are completely inverted. For-profit insurers have a fiduciary duty, a literal legal obligation to their investors to maximize profit. And how does an insurance company maximize profit? By taking in as much in premium dollars as possible and avoiding paying out claims.
They want to collect premiums and deny service.
The incentive is to aggressively screen out sick people through underwriting, to deny coverage whenever possible, and to build massive bureaucratic walls. This multiplies administrative complexity exponentially.
I think the best way to conceptualize this is the restaurant cost shift metaphor. Because we have countless different payers in the US with different fee schedules, doctors and hospitals naturally shift costs. Imagine walking into a restaurant with 3 friends.
This is a great analogy.
The first friend has a coupon that says the restaurant can only charge him $10 for a steak. That's Medicare or Medicaid. The restaurant loses money on him. The second friend has no money at all and eats a burger for free, which is the emergency room charity care.
Right.
So when the third friend, the guy with private employer-sponsored insurance, orders a simple side salad, the restaurant charges him $500 to cover the losses of the other 2. That is the American cost shift in a nutshell.
It's an incredibly accurate metaphor. When payment is fee-for-service across a fragmented array of payers, volume expands and costs shift. If Medicare cuts its payout for a procedure because of a federal budget crunch, the hospital doesn't necessarily become more efficient. It simply raises the price of that exact same procedure for private insurers to make up the margin.
So the exact same operation on the exact same day in the same hospital can have 10 completely different prices depending on who is footing the bill.
Exactly. The system incentivizes volume, aggressive billing, and cost shifting rather than baseline efficiency.
But let's look at the inverse incentive. The logic of prevention. When a nation ensures universal coverage, like in the UK or Taiwan, the system takes on a totally different posture.
It has to. In a universal system, the state or the public insurance fund is financially responsible for that citizen's health for their entire life. From a purely economic standpoint, keeping that citizen healthy over their lifespan saves the system millions of dollars.
So prevention becomes a highly rational economic incentive.
Absolutely. Preventative care, free physicals, anti-smoking campaigns, early interventions, these become highly rational, economically incentivized behaviors for the system to aggressively pursue. In America, your private insurer doesn't want to pay for preventative care because statistically, you'll likely switch jobs and be on a different insurance plan in 3 years anyway.
Right. Why pay for your treadmill test today if a different company is going to be paying for your heart attack in 10 years?
They have zero incentive to invest in your long-term health.
Yeah.
The risk is too fragmented.
To really test all of this, to move from abstract systems to lived experience, the author, T.R. Reid, literally takes his own body on a global tour. And this is where the deep dive gets intensely personal and really illuminates these systemic contrasts.
It's a brilliant framing device.
Reid has this ruined, incredibly painful right shoulder from an injury during his time in the U.S. Navy decades ago. He can't swing a golf club. He can barely reach overhead to change a light bulb. He's in constant agony. So he decides to present his shoulder to doctors around the world to see how these different systemic incentives actually dictate patient care.
It is a real-world diagnostic test of the systems themselves. It illustrates perfectly how a patient's medical pathway is shaped by institutional design rather than random luck or just the individual personality of the doctor you happen to see?
So he starts at home in the US. He goes to a highly skilled, brilliant American orthopedic surgeon. And the American pathway perfectly reflects the high-tech, aggressive, fee-for-service ethos of our system.
Volume and intervention.
Right. The doctor takes some scans and immediately proposes what's called a total shoulder arthroplasty. On the official billing charts, it's procedure no 08.81. And just to be clear about what this means physically for you listening, this is a massive invasive surgery. It involves surgical saws, chopping off the natural joint bone, and cementing a bulky titanium and silicone contraption deep into his clavicle and humerus.
And when Reid asks the two most fundamental questions any consumer would ask, what are the risks and how much will it cost, the system's opacity becomes glaringly obvious.
The surgeon tells him the risks include serious infection, nerve damage, paralysis, and death. And when he asks about the price, the surgeon honestly tells him he has absolutely no idea.
You can't know.
The surgeon literally cannot tell him what the surgery will cost because the price is hidden in the labyrinth of insurance tiers, in-network versus out-of-network negotiations, and that cost-shifting restaurant dynamic we just talked about. It's a drastic, expensive, dangerous, and completely opaque pathway.
Now, contrast that with the pathways generated by different structural incentives globally. He takes the exact same shoulder to Japan. Japan boasts incredibly fast access, so Reid literally walks into a top-tier hospital, Kyoto Daigaku Hospital, and sees the nation's top orthopedic surgeon on the exact same day with zero appointment.
Which is mind-blowing for an American used to waiting 3 months to see a specialist.
Exactly. The Japanese surgeon examines him and completely pumps the brakes. He offers a variety of physical therapies and targeted steroid injections, noting that radical titanium surgery isn't the best first step for joint stiffness. He essentially says, why would we chop off your bone if we haven't tried rehabbing the muscle?
He's conservative with the intervention.
But here's the kicker. If Reid decides he does want the surgery, the price is not a mystery. It is dictated by that universal fee schedule. The surgeon can tell him to the penny what his out-of-pocket exposure will be.
And then he goes to Germany, the Bismarck system. There, he experiences the gatekeeper model. He can't just walk into a specialist's office. A general practitioner thoroughly evaluates him first, acting as a filter.
And then she consults this massive, highly regulated national directory called the GO.
We need to explain this because it's so foreign to Americans. The GO is effectively a giant national menu with legally binding prices for every conceivable medical action.
It represents the negotiated consensus between the private sickness funds and the private doctors. The directory dictates exactly what procedures the funds will authorize and cover, and under what circumstances. The GP looks at the directory, and it gives a green light for the total shoulder replacement if Reid wants it.
But the price is the crazy part.
Right, because the system relies on deep risk pooling and standard pricing. His out-of-pocket cost for a massive titanium surgery would be a couple of small copayments, roughly $30. The transparency is absolute, and the financial terror is removed entirely from the medical equation.
But the most striking contrast, the one that really challenges our perception of what medicine even is his experience in India, at the Arya Vaidya Chikitsalayam clinic. This represents a blend of traditional medicine operating within its own localized, market-dominant system. He is evaluated by a woman named Mrs. Rama.
Yes, Mrs. Rama sweeps into the hospital room in a salmon-pink sari. She doesn't ask for an MRI. She sets up a board with cowrie shells, rocks, and statuettes of Hindu deities. She is an expert in yajnapathy, which for our listeners is roughly equivalent to complex astrological charting. She takes his exact time and location of birth to map the cosmos.
And what is vital to understand here is that Mrs. Rama's diagnostic work, determining if the stars and planetary bodies are properly aligned for Reid's healing, is actually an officially recognized, integrated, and insurable step in that specific Indian medical system.
It's a vivid demonstration of how a local institutional architecture defines what constitutes valid, rational care.
An American insurance company would laugh you out of the room for submitting an astrology bill, but in that specific Indian context, it is systemically valid and economically supported.
And this brings us to a critical analytical point, and one we must be very clear about. Let me ask you, when you read about the American doctor proposing saws and titanium with hidden prices, does it make the U.S. doctor sound malicious?
It does on the surface. It sounds like he just wants to cut him open to buy a new boat. But are we actually saying the U.S. doctor is a bad guy?
Absolutely not. And that is the brilliance of a systems-level analysis. Reid's journey is not a critique of the individual American doctor. That American orthopedic surgeon is brilliant, highly trained, and operating entirely rationally within his environment.
He's just playing by the rules of the game he's in.
Exactly. The analysis shows us that the system's incentives dictate the reality. The U.S. system incentivizes and financially rewards high-tech, aggressive, expensive interventions. The Japanese system incentivizes quick access, low margin volume, and strict price controls. The German system incentivizes clear, transparent gatekeeping. The individual doctors are just playing the game. If you put the American doctor in the Japanese system, his behavior would adapt to those rules instantly.
So we've looked at the design of these architectures and we've explored the incentives they create. Now we have to trace the predictable structural outcomes. What happens when you let these different architectures run for a few decades? Reid pulls together some stark data, and the contrasts across countries are staggering. Let's start with administrative overhead variation.
The hidden drain on the system.
We mentioned earlier that the U.S. system is incredibly complex. Prominent economists call it an administrative monstrosity. Up to 20% of every premium dollar spent in the U.S. goes to non-medical costs. Think about that. 20 cents of every single dollar you pay in premiums goes to marketing, risk underwriting, corporate profits, and literal armies of clerks engaged in what the industry calls denial management.
Denial management is a massive parasitic industry within the U.S. system. You have highly paid professionals working for insurers whose entire job is to find technicalities to refuse payment for a procedure. Then hospitals have to hire their own armies of coding experts and billing compilers to fight the insurer's denial managers.
It is an administrative arms race.
An incredibly expensive arms race, and none of it heals a single patient.
Now, compare that 20% overhead to the outcomes of a unified system. In France, where they use a universal digital system anchored by their carte vitale smart card, the doctors don't even hire billing staff. A patient hands the doctor the card, it goes into a reader, and the payment is routed automatically from the national sickness funds. As one French doctor told Reid, c'est automatique, the administrative overhead in France is roughly 5%.
And then look at Taiwan.
Right, Taiwan. The book notes Taiwan's administrative overhead is under 2%. Under 2%. Even standard charities hover around 10 to 15% overhead. How is a national government running a massive healthcare apparatus for millions of people at under 2%?
Because they designed it from scratch in the digital age. They gave every citizen a smart card containing their entire medical history and billing profile. When a patient visits a clinic, the card is swiped, the data is instantly uploaded to the central government payer, and the clinic is paid electronically.
No paper, no friction.
No paper forms, no marketing departments trying to lure in healthy 20-somethings, no underwriting departments trying to exclude people with asthma, and no profit layer. It is a pure, frictionless transaction pipeline.
And that leads directly into the macro cost differentials across nations. Because of this incredible administrative bloat plus the lack of central price negotiation, the U.S. spends about 17% of its entire gross domestic product on healthcare. That is a staggering sum of wealth.
It is entirely disproportionate to the rest of the world.
Meanwhile, Germany spends about 11% of its GDP, Japan spends 8%, Taiwan spends around 6%, and all of those other nations provide universal coverage. They cover every single citizen, from birth to death, for a fraction of what the U.S. spends, while leaving millions entirely uninsured.
Which brings us to public health performance differences. Spending the most money should theoretically yield the best results. We like to believe we have the best healthcare in the world. But when the World Health Organization ranked the overall performance, quality, and fairness of national healthcare systems, France ranked #1.
And the U.S.?
The United States ranked 37th. We placed just behind Costa Rica.
And behind all those numbers, behind the GDP percentages, the WHO rankings, and the administrative overhead stats are actual human lives. The system produces access disparities that are genuinely tragic. Reid tells the story of Nikki White. She was a 32-year-old American woman, a bright, ambitious college graduate. She contracted systemic lupus erythematosus.
We should explain what that disease is because it's critical to understanding her fate. Lupus is a severe autoimmune disease. The body's immune system essentially becomes hyperactive and starts attacking normal, healthy tissue. It can attack the joints, skin, kidneys, blood cells, brain, heart, and lungs. It is incredibly painful and dangerous.
But it's treatable.
Highly treatable. With modern medicine, with the right combination of corticosteroids and immunosuppressants, it is highly manageable. People with lupus can live long, productive, normal lives. If Nikki lived in Japan or Germany or the UK or Canada, she would have received standard treatment, managed her symptoms, and lived. But she lived in the United States.
And because she lived in the US, she fell into the chasm between the demographic silos we talked about earlier. Once she became too sick to work consistently, she lost her job. And because health insurance in America is tied to employment, she lost her private health insurance. She tried to buy an individual policy, but because lupus is a chronic pre-existing condition, she was mathematically unprofitable for any private insurer to cover.
They either flat out denied her or quoted premiums that were astronomical.
So she was pushed out of the private Bismarck silo. Her next logical step would be the government safety net. But the American system relies on strict means testing. Nikki had slightly too much money, a meager savings account, maybe an old car, to qualify for government welfare programs like Medicaid, which require you to be practically destitute.
She was too rich for welfare and too sick for private insurance.
She was trapped in the out-of-pocket model. She spent the last months of her life frantic. She wrote letters to politicians. She pleaded with hospital administrators, begging for help to get the basic drugs and doctors she needed to survive. She suffered immensely. And she died at 32 years old.
It's devastating.
As her primary doctor, Emmeline Crawford, said through tears, Nikki didn't die from lupus. Nikki died from complications of the failing American healthcare system. It was a lack of access to healthcare that killed Nikki White.
It is a profound structural failure, and it illuminates the ultimate moral outcome of the system's design. Systems force outcomes that reflect their underlying values. By tolerating a fragmented system that views healthcare largely as a free market commodity to be bought and sold rather than a human right, the U.S. implicitly accepts massive collateral damage.
It's a choice the system makes.
Yes. Research indicates the U.S. accepts roughly 20,000 avoidable deaths a year, purely due to a lack of access to insurance. It also accepts hundreds of thousands of massive medical bankruptcies every single year, families losing their homes because someone got cancer. These two phenomena, avoidable deaths from lack of insurance and medical bankruptcy, are completely non-existent in all other industrialized democracies. They literally do not happen in France or Japan or the UK.
That is incredibly heavy. When you lay it out like that, it really forces you to ask, if the outcomes are this stark, if the administrative waste is this massive, and if the human toll is this tragic, why does the system stay this way? This brings us to the persistence of these systems. Map out the feedback loops and institutional reinforcement for us. How do these massive institutional architectures sustain themselves over time? Why don't they just collapse under their own weight?
They sustain themselves through incredibly powerful feedback loops. Let's look at the virtuous cycle of universality found in other countries. When a system provides universal coverage, it inherently creates a massive, unified risk pool. Everybody is in. Because the pool is massive, it gives the system immense bargaining power to negotiate lower prices for drugs, hospital stays, and medical devices.
Negotiated pricing lowers costs.
Exactly. Those negotiated lower prices keep the overall costs down. Lower costs make the universal system politically sustainable and widely popular with the public. And that immense political commitment to universality stabilizes the reform and reinforces the mandate to maintain the system's market monopoly, keeping bargaining power high. It is a closed, self-stabilizing loop of efficiency and coverage.
Okay, so that's the virtuous cycle. The system works, people like it, so they protect it, which makes it continue to work. What about the vicious cycle of fragmentation we see in America? How does that perpetuate itself?
The vicious cycle operates on the exact opposite logic, but it is equally self-sustaining. In the U.S., you start with a fragmented system of hundreds of different payers. This fragmentation vastly increases billing complexity. That complexity forces hospitals and doctors to hire armies of billing staff and compilers just to navigate the maze of different insurance requirements.
Complexity raises overhead.
Right. This explosion of administrative staff drastically raises the overhead cost of delivering care. To cover those skyrocketing overhead costs, the hospitals must raise their prices. To survive the rising prices, insurers must further fragment the risk pool, aggressively denying claims and pushing out sick people to maintain their profit margins. This creates even more complexity, which requires more administrators, which raises costs again. Unstable coverage generates political backlash, but the overhead reinforces the fragmentation. It is a vicious, accelerating cycle of bloat and exclusion.
So why is it so incredibly hard to change? If the vicious cycle is so obvious, and we can look at Taiwan or Germany and see a better way, why can't we just snap our fingers, pass a bill, and adopt the French or Taiwanese model tomorrow? I mean, Taiwan literally just copied the best parts of everyone else. Why can't we?
Because of embedded stakeholders and the gravity of path dependence, once you build those massive administrative layers, The for-profit insurance companies, the pharmaceutical lobbying groups, the billing compiler firms, the denial management departments, they become deeply embedded in the national economy.
They aren't just abstract concepts.
No, they are massive corporations that employ millions of people. They generate billions of dollars in profit. They fund political campaigns. Any structural reform that aims for true efficiency threatens a massive redistribution of power and capital away from those exact stakeholders.
Right. If we move to a Taiwanese system with 2% overhead, what happens to the hundreds of thousands of Americans whose entire livelihood is based on navigating the 20% overhead of the current system?
Exactly. The administrative layers create a profound path dependence. The system becomes too big, too complex, and too profitable for the gatekeepers to easily dismantle. It creates immense institutional inertia.
But it's not just about money, lobbyists, and stakeholders. Systems reflect moral commitments about entitlement versus commodity. Reid makes the point that healthcare systems ultimately reflect a nation's core values. Specifically, whether they view medical care as an entitlement of citizenship, a human right, or as a standard market commodity, like a television or a car.
In the UK, Nigel Lawson, who was Margaret Thatcher's budget director, noted that the National Health Service is the closest thing we have to a religion. Even Margaret Thatcher, the Iron Lady of ruthless privatization and conservatism, wouldn't touch the NHS. She knew that the moral commitment to universal, free care at the point of service is deeply, irrevocably woven into the British national identity.
A phenomenal example of how this moral commitment can overcome even the most entrenched, profitable stakeholders is Switzerland in the 1990s. This is a story Americans rarely hear. For a long time, Switzerland had a healthcare system very similar to the U.S.
Highly deregulated.
Right, they had heavily deregulated for-profit insurance companies that were competing fiercely, aggressively denying claims and screening out sick people to maximize returns for their shareholders. By 1993, this unfettered capitalism resulted in about 5% of the Swiss population losing their health insurance.
Which is wild to think about.
Yeah.
In the U.S., where roughly 15 or 16% of the population is routinely uninsured, getting the uninsured rate down to 5% sounds like an absolute utopian dream.
But to the Swiss, it was a national crisis. The lack of coverage for that 5% was seen as an unacceptable moral failure. It violated their core national value of solidarity. They looked at their society and decided it was fundamentally wrong that some citizens could face financial ruin while others profited off their illness. So, despite incredibly heavy lobbying from their massive, powerful, and profitable insurance industry, the Swiss public and government forced through a massive reform known as La Mall.
They completely flipped the script. They legally forced all the private insurance companies to revert to nonprofit status for basic medical care and mandated that everyone be covered. They actively chose national solidarity over unfettered market profit in the financing of human survival.
And that concept of solidarity really clarifies how foreign systems define their boundaries. Because resources are finite, no system on Earth can offer infinite cutting-edge care to absolutely everyone without going totally bankrupt. So universal systems establish a floor and a ceiling.
Exactly. The floor is a baseline package of high-quality, essential medical care that is guaranteed to absolutely every citizen, regardless of their wealth, their employment, or their health status. Everyone gets the floor. But to afford that floor, they also establish a ceiling.
They set strict limits.
Yes, limits on the extent of experimental, aggressively high-tech, or marginal care the public system will fund, particularly at the end of life. As a British health minister once summarized it, we cover everybody, but we don't cover everything. If a new cancer drug costs $1 million but only extends life by 3 weeks, the British system might refuse to cover it, prioritizing the floor of basic care for millions over the ceiling of extreme care for a few.
And when you look at the U.S. system through that lens, it is completely uniquely deformed. The U.S. system has no floor and it has no ceiling. There's no guaranteed baseline. As we saw with Nikki White, millions of people get absolutely nothing or rely on catastrophic emergency room charity. The floor drops completely out, but at the exact same time, there is no ceiling. If you are ultra-wealthy or possess a top-tier platinum insurance plan, the U.S. system will provide virtually infinite, cutting-edge, astonishingly expensive care, utilizing the most advanced technology on Earth to extend life at all costs.
It is a system of staggering, unfathomable extremes.
Let's zoom out even further and reconnect to larger nested systems. Healthcare isn't just a standalone sector in a vacuum. It is nested within even larger societal systems. Because we tie insurance to employment, which, remember, is a legacy we inherited from Bismarck's original 1883 design, the American system deeply warps our labor markets.
It creates massive job lock. People stay in jobs they absolutely despise, or they delay starting innovative new small businesses simply because they cannot risk losing their family's health insurance. It stifles entrepreneurialism.
Furthermore, it aggressively penalizes decent employers. Think about a medium-sized American manufacturing company that wants to do the right thing and provides great health benefits to its workers. That company faces a massive, crushing cost disadvantage compared to a foreign competitor in Canada or Japan whose government handles the entire healthcare burden. The American company has to bake the cost of premiums into the price of their products, making them less competitive globally.
It also intersects deeply with pharmaceutical pricing structures. Because the U.S. doesn't negotiate centrally, American consumers end up essentially subsidizing the global pharmaceutical industry's research and development by paying wildly inflated prices for drugs that cost a fraction of the price in Europe.
It also intersects with political ideology about markets versus rights, often in ways that completely contradict historical reality. The American debate is perpetually stuck in a shallow rhetorical loop of capitalism versus socialism. But the history of these global models shatters those binaries. Otto von Bismarck, the architect of the universal mandated sickness funds in Germany, was not a socialist. As we established, he was a ferocious conservative. He built the welfare state explicitly to unify his empire and neuter the left-wing parties.
And on the flip side, you have Nye Bevan in Britain, who was a pugnacious, die-hard socialist who wanted to literally take the money out of medicine by building the NHS. Universal care has been championed by both the extreme right and the extreme left globally for very different ideological reasons. It's not owned by one political philosophy. It also gets tangled up in our federal versus national governance structures where states have massive power over Medicaid, creating further regional disparities.
So we have covered a massive amount of ground. We've looked at the architectures, the incentives, the tragic outcomes, the economic bloat, and the nested societal systems. Which brings us to the ultimate question of this entire deep dive. What is the crisis in perception here?
The crisis in perception is fundamentally about what we failed to see in our public discourse. What is misperceived is the nature of healthcare itself. In our media and political debates, healthcare is constantly treated as a binary. It is either perceived as a purely economic commodity to be distributed by free markets, or it is perceived as a purely moral charity to be administered by a monolithic state. This endless, exhausting binary debate completely obscures the true structural layer governing reality, which is incentive design and risk pooling.
It hides the mechanics.
Completely. Surface debates about socialism versus capitalism completely fail because they rely on myths. Americans largely assume that any form of universal care equates to European-style socialized medicine. Yet, when we analyze systems like Germany, Switzerland, or Japan, we see heavily privatized free market architectures. The doctors are private businesses, the hospitals are private, the insurers are private. What they've done is simply remove the profit motive from the financing layer, ensuring that the risk pool includes everyone. They solved the problem with regulated capitalism.
And the reverse is true, too.
Yes. The rhetoric completely ignores that America already hosts one of the largest, purest socialist medical systems on planet Earth. The Veterans Affairs System, where the government owns the hospitals and employs the doctors. How systems-level comparison changes visibility is profound. When you apply this comparison, you achieve sudden, clarifying structural clarity. You stop blaming individual bad actors. You stop blaming the greedy doctor with his surgical saws, or the bloated government bureaucrat. And you realize that an uncoordinated, fragmented system built without universal risk pooling naturally predictably outputs high costs, immense bureaucracy, and deep inequity. The crisis in perception is our inability to see that the outcomes we hate are not accidents. They are exactly what the system is currently designed to produce.
That visibility is so crucial. If you change the design, you change the incentives. If you change the incentives, you change the outcomes. You can't just yell at the system to be better while leaving the structural architecture intact. I want to leave you, the listener, with a final thought to mull over. We've talked extensively about how a nation's identity is defined by the systems it chooses to build. What does it say about a society, about its core values and its perception of its own people, when its most efficient, completely unified, and fully socialized system of care is reserved exclusively for its soldiers, while its civilian population is left to navigate a chaotic, profit-driven marketplace where a diagnosis can mean bankruptcy or even death?
Crisis in Perception examines how systems shape belief and how better tools help us see clearly.
This project is free and publicly accessible. If you'd like to support the time, tools, and research behind crisis and perception, you can become a supporter on Patreon.
For a shorter visual overview of this topic, see the mini explainer linked in the description.
If you enjoy this kind of systems-level analysis, please like, subscribe, and comment with books or topics you'd like us to explore next.